So, good evening, everybody, and a warm welcome or welcome back to our webinar series on TB whole genome sequencing. Our title for today's webinar is really interesting: Whole Genome Sequencing, a Swift Army Knife for TB Diagnosis. And like the multi-utility that a Swiss knife is, I believe that TB whole genome sequencing also has the same utility. I am your moderator for the session. My name is Dr. Aparna, Bhanushali, and I lead the initiatives, the scientific initiatives at HaystackAnalytics. This webinar, as most of you would be aware, is a collaborative effort by HaystackAnalytics Private Limited and Thyrocare Technologies. Haystack is a startup which is incubated in IIT and believes in bringing innovative genomic solution. TB whole genome sequencing is one of such innovative solution. And Thyrocare Laboratories, of course, is a very well-known diagnostic service provider. It is a laboratory which is a part of the IPACT consortium. The IPACT is the initiative for promoting affordable and quality tests in TB, and Thyrocare has adopted several firsts under its FocusTB vertical. So with that, I would like to come, can I have the next slide, please? I would like to introduce our guest speakers. Our chief guest speaker for today is Dr. V. Anilkumar and also Dr. Chaitali Nikam. Can I have the next slide, please? Dr. Anilkumar has 15 years of experience as a clinical microbiologist. He is presently the clinical professor and HOD microbiology at Amrita Institute of Medical Sciences in Kerala. He is a fellow of European Confederation of Medical Mycology, has published 163 articles in national and international journals, and is also the peer reviewer for more than 25 different reputed journals. So welcome to Dr. Anilkumar, and I really look forward to having listening to a very interesting session from you.
Thank you, Bhanushali.
Our next guest speaker is Dr. Chaitali Nikam. Most of you would, Dr. Chaitali needs no introduction. She has been a guest speaker on several of the webinars. She holds the infectious disease portfolio at Thyrocare Laboratories. She's also the member of the Constitution of the National Technical Working Group on Private Provider Engagement under the NACP, the member of the National Technical Working Group on Collaborations between NTVP and corporate hospitals and laboratories, and has greater than 38 publications in peer-reviewed journals. Welcome, Dr. Chaitali. So just a few of the housekeeping rules that we would appreciate if most of the questions could be typed in the chat box, and we will try to answer as many as possible within the time frame. If we're not able to answer most of them, we will try and get back to you, and hope you all have been receiving the recording of the webinar also. Alternatively, you could raise your hand, but in my experience, I've seen that most of the times, even when we unmute the participants, then there is a lot of time lag which happens between the questions being asked. So anyway, it's a choice. So without much further ado, I will please ask Dr. Anilkumar to start with his webinar.
Okay, good evening, everyone. I hope I'm audible.
Yes, perfectly, Dr. Anilkumar.
Thank you. Good evening once again. Thank you for the kind introduction, madam. And I thank all the delegates for joining on a very long, happy weekend. We have 2 consecutive holidays. Very rarely we get such an opportunity. So sparing 1 hour for our program, I really thank you for joining. So I'll be talking on whole genome sequencing, my experience with the utility of whole genome sequencing, how I used it and what I faced. So to begin with, this a disclaimer. Whole genome sequencing is an amalgamation of molecular biology, bioinformatics, and clinical microbiology. And I am a clinical microbiologist. I'm not a molecular biologist or a bioinformatic person. So I don't know the nitty-gritties of whole genome sequencing. I won't be able to troubleshoot those nitty-gritty questions. So I am a clinical microbiologist pertaining with selection of the sample and the correct sample, right sample to be sent for whole genome sequencing, and how to make sense of the report that it comes. So no hands-on experience on WGS. WGS was outsourced. My personal limited experience on the clinical utility is based on the outsourcing of WGS to Thyrocare FocusTB consortium with Haystack Diagnostics. So this is the pillars of microbiological diagnosis. If you want to diagnose mycobacterial infection or TB, you have to first detect TB, and we have plenty of methods to detect TB. Then you have identification, DST, and then you do a cluster analysis. Now, cluster analysis is something that has come into vogue because of whole genome sequencing. So there are many methods for detection and identification. DST, you have phenotypic DST, which takes about 4 weeks, 3 to 4 weeks for liquid culture. So it's a long duration. So if you look at whole genome sequencing, it manages to do identification, DST, and cluster analysis in a single assay. It takes 14 days if you give them a culture or a sample. It depends on the lab whether they process the sample or the culture isolate. So whole genome sequencing is like a Swiss Army knife, which can be used very well in diagnosing and treating, identification and treating, and also identifying outbreaks in case of tuberculosis. So we'll be discussing as we proceed. So this is the algorithm for diagnosis of TB. You usually have a clinical diagnosis in case of the clinician who thinks the patient is suspected to have TB. You do a smear AFB, culture AFB, or a CBNAT. CBNAT is widely available. We all use CBNAT very frequently. And if it comes positive, we go for a drug susceptibility. It could be partial drug susceptibility using a line probe assay, or a drug susceptibility using the phenotypic assay, which could be first line, then reflex second line if the first line comes resistant. So it's a long duration, long way to go before we come to know the susceptibility for all 18 drugs that's available for treating TB. So there, the whole genome sequencing comes into picture. Now, whole genome sequencing, there are two different types. Whole genome, actual whole genome sequencing, where the whole genome of the bacteria is sequenced and analyzed. So it's a huge amount of data that is, each mycobacteria is 4.4 billion base pairs, and 4,000 genes are there, and you have the data produced would be something around 3 to 4 GB of data. So make sense of that 3 to 4 GB of data. Base pair data is very difficult, and it's a very tedious procedure. You need good bioinformatics person and a good molecular biologist to get such robust data. And then comes a targeted NGS. Targeted NGS is a cheaper and shorter version of whole genome sequencing, where you don't amplify the whole gene, the 4.4 million base pairs. You amplify only 10,000 base pairs, or you amplify only 50 to 100 genes. You don't amplify the 4,000 genes. You may not require 4,000 genes. So we target a few particular genes that are responsible for resistance or identification, amplify it, and then do a whole genome sequencing using an NGS, and then come to a conclusion. So it's a shorter version, and it's cheaper alternative, and it can be done directly on samples, very effective. So that's targeted NGS and whole genome sequencing in brief. So this is a snapshot of what happens in the whole genome sequencing. I won't go too much into details. I'll just tell you that what happens. That depends on the lab. If the lab says that I can process a sample for whole genome sequencing, you can just sample. If the lab says that it works only on isolates, you can send mycobacterial isolates. They extract the DNA, cut the DNA into small pieces. They may prepare library, and ultimately they feed into the whole next generation sequencer. A database is produced. The data is the whole sequence is analyzed. If it's a whole genome sequencing, the data is 3 GB, a huge amount of data. The bioinformatic person will align it, make sense of it, and then use these databases that are publicly available. MTB, SIG, ReSIG, TB, and Cryptic. These are different databases that are available online, where they feed the data and analyze and try to make sense of what's happening with the mycobacteria. They try to identify the SNPs, the single nucleotide polymorphism, that is a change in the sequence of the base pairs. Change in the sequence of base pairs is identified. These change in the sequence of base pairs will ultimately lead to tell you which gene is involved and the mutation that it confers. The mutation will also identify the amino acid chain that happens. So if all these things are identified by using this database, and once the mutation is identified, it also tells you whether it's clinically relevant, whether it confers phenotypic susceptibility also. So that way you get a susceptibility for different drugs based on the different genes where the SNP is identified. And then another advantage is that by knowing the whole sequence of the bacteria, you can also identify the strain. If it's Mycobacterium tuberculosis, you can identify the lineages, lineage 1, 2, 3, or 4. And if it's not Mycobacterium tuberculosis, you can identify non-tuberculous mycobacteria. You can identify the different members of the Mycobacterium tuberculosis complex, like the Mycobacterium bovis, Microti, africana. It's very rare to find bovis, microtia, or Africanum in Indian setup. Most often you will get a report saying that it's lineage 1, 2, or 3 of Mycobacterium tuberculosis complex. All these are compiled together to produce a report with all these details included. So that is how whole genome sequencing of Mycobacterium tuberculosis occurs in short. So it depends on the lab, but the lab would like to is comfortable in sequencing the sample or sequencing the Mycobacterium isolates. So whole genome sequencing, if they are doing whole genome sequencing, all 18 known drugs, the resistance can be determined. So all the genes are analyzed, 4,000 different genes are analyzed, including the genes encoding for these all 18 drugs. So all 18 drugs can be determined. Resistance to all 18 drugs can be determined. If you're doing a targeted NGS, somewhere around 10 to 12 drugs only could be determined, because it's a multiplex PCR where they include only specific genes that are relevant. So you may not achieve the whole 18 drug panel. You will achieve only 10 to 12 antibiotics at the most in case of targeted whole genome sequencing, targeted NGS. And once the SNP is identified, the mutation is identified, then comes the job of identifying the confidence level for the mutation to be associated with the resistance, phenotypic resistance. So there will be a lot of SNPs that are identified, a lot of mutations, but some mutations are benign, do not confer resistance. So if there's a high association, high confidence, that means a strong association is there. It is known to cause phenotypic resistance. It is reported as resistance. Moderate means moderate association is there. More data is required. You have to identify. You cannot report it as resistant, but you can report it that there is a mutation that has been identified, which is of moderate significance. It may not be associated with phenotypic resistance. Minimal is something that is totally benign. It doesn't confer any phenotypic resistance. So you get a lot of mutations, SNPs, but it did not confer phenotypic resistance based on the association, high, moderate, or minimal association. So let's look at a particular report of 3 strains, strain 1, strain 2, strain 3, and strain 4, where we send these isolates and it underwent a whole genome sequence. The first thing you identify is the lineage of 4, 3, 1, and this particular strain was not Mycobacterium tuberculosis, it was Mycobacterium bovis. And these 3 were Mycobacterium tuberculosis, so lineage 1, 3, and 4 were identified. When you look at RPOB mutation, that is confers resistance to rifampicin, strain 1, 2, and 3 had the mutation which conferred high level of resistance to rifampicin, so they were reported as resistant. But Mycobacterium bovis had an SNP, a mutation that didn't confer resistance to rifampicin, though it was reported as rifampicin susceptible. So this is a benign mutation, so it will not be such reported as resistant. Similarly, in case of pyrazinamide PNCA mutation, strain 1, 2, and 4, the mutations were significant, conferred resistance, so they were reported as resistant. In case of strain 3, the mutation that was identified did not confer phenotypic resistance, a benign mutation, so it was reported susceptible. So in a whole genome sequencing report, you may find mutations which may have minimal or moderate association, so it may not be reported as resistant, it will be reported as sensitive. So after knowing the resistance phenotype of the bacteria, you can also identify whether they are clustering or not. So you have the whole data of the bacteria, the lineages and all the SNPs. So depending on the number of SNPs, if the SNPs in a two strains are less than 10, something around 5 to 12 SNPs, then they are almost identical. Those bacteria are almost identical. It could be either recent transmission or it could be a contamination. It could be an outbreak, a clustering, or it could be a contamination also. If the lab is sending similar isolates through whole genome sequencing, you can question the lab saying that you are having identical isolates being sent for different patients. Please check whether it's contamination or not. So you can identify outbreaks by looking at the whole genome sequencing data. But this is not possible if you do a targeted NGS. Targeted NGS will not have that much amount of data to come to a conclusion whether there is an outbreak or not. So WGS also helps us to identify relapse and reinfection. Relapse is recurrence of the same original infection. So if the SNPs are less than 10, 2 different strains have been identified. From a previous infection, you have a whole genome sequencing data, and a recent infection, you have a whole genome sequencing data. You compare both of them. Both the isolates have the SNPs, number of SNPs is less than 10. It is a relapse. Reinfection is you have an infection with a totally different strain. That is, you have the whole genome sequencing data of the first isolate, the second isolate also you have, and the difference in SNPs is more than 100. It means that it is a reinfection, a new strain that is causing infection. TB relapse rate is very high in India, 10%. So it makes sense to identify whether it's a relapse or reinfection in Indian setup. It also identifies mixed infections. Mixed infections could be either an infection with MTB or NTM, or it could be between two different strains of mycobacteria having two different phenotypic resistance mechanisms. One is sensitive, one is resistant. So having a mixture of mycobacteria also complicates the treatment and the outcome of the patient, because these may not respond to the normal antitubercular therapy. If you're targeting the sensitive pathogen, because the sensitive pathogen is more likely to grow in the culture, and you're more likely to do a DST for the sensitive pathogen because of the fitness cost associated with developing resistance. So more likely you are going to miss it in phenotypic susceptibility, and it may lead to poor outcome. So it's better the whole genome sequencing comes into the picture, saying with more data saying that it is a mixed infection with two different strains having different susceptibilities. So better to treat the resistant infection also. So published data from Western literature shows that the sensitivity and specificity of WGS when compared to the gold standard DST is very, very good. 97%, 99% for isoniazid, rifampicin, ethambutol. Everything is more than 90%. But if you look at the Indian data, the sensitivity is somewhere around 70 to 80%, specificity also from 70 to 80%, because the gold standard DST may not be as great as what is used in the Western countries. So your DST should be very, very perfect. We all know that pyrazomite susceptibility has got a lot of false positivity because the pH level has to be maintained. So you should be having a very, very good lab to do a DST to compare it with whole genome sequencing. If your gold standard DST is inferior, then your susceptibility and sensitivity will suffer. So it has got excellent sensitivity and specificity, provided you compare with the gold standard DST, which is done very properly. Ethinomide has got poor specificity because usually the whole genome sequencing picks up INHA mutation to look for ethinomide susceptibility resistance. But there are many other genes that are responsible for ethinomide resistance that may not be looked into. They don't have data about it, whether it confers phenotypic resistance. So data is lacking. So as a result, ethinomide has got a poor specificity and sensitivity. So this is an article where they compared 20 MDR and 5 XDR TBs. They were all resistant by GeneXpert rifampicin resistant. So they did line probe assay, they did phenotypic DST, they did an expert, and they compared everything, and they did the whole genome sequencing and compared the agreement between each other. When they compared the culture DST with the expert is rifampicin resistant, when they considered rifampicin only resistant, then the association agreement was only 49%. But if you by default consider all rifampicin resistant isolates as resistant to INH also, the agreement increased to 68%. That's what we do in India. Any rifampicin resistant isolate in GeneXpert is by default considered MDR unless and until proved otherwise. So we'll have a agreement of only 68% in that case. When culture DST was compared with line probe assay, the agreement was only 63%. But when culture DST was compared with whole genome sequencing, the agreement was 93%. So whole genome sequencing gives you the best agreement when with DST. So whole genome sequencing should be the way forward for doing genotypic DST rather than doing a phenotypic DST in case of Mycobacterium. Now, whole genome sequencing has been endorsed by FIND and WHO. They have a technical guide. It's freely available online. You can look into it. So they also endorse whole genome sequencing for genotypic drug susceptibility rather than going for a phenotypic susceptibility, which takes long. Especially for first-line antibiotics, it is an excellent choice. So let's discuss a few cases that we had outsourced and what happened to these. So this is a case one, a 19-year-old female, February 2020. You see the chest X-ray. She had pulmonary tuberculosis, sputum positive case, and September 2020, only 19-year-old. She was underweight and the consolidations increased, the X-ray is worse, and we don't know what happened. So we were really worried that the patient has got an MDR TB. So this is the whole sequence. In January, she came with culture positive, smear positive, GeneXpert positive, rifampicin is negative. So since she was not doing fine, the clinician added streptomycin and levofloxacin was added to the regimen. September again, she came back with the same old things. Sputum was positive, culture was positive, GeneXpert was positive, rifampicin again resistance was negative. And additionally, she developed cecal ulcers also with tuberculosis. So that was also positive. So we decided to send a whole genome sequencing for the isolate as well as the sputum. Direct sputum also we sent for whole genome sequencing. And the sputum whole WGS failed for some, because there are inhibitors, it's very difficult to do a sputum whole genome sequencing. Direct samples, it's very difficult because there are a lot of inhibitors, the amount of DNA may not be adequate, the confidence level will not that great. So culture isolate was positive whole genome sequencing. It was susceptible. Lineage 1 was identified. It was not an MDR. So our fear of MDR was removed, that it was not an MDR. It was confirmed. Then we sent her to a higher center. Why she is not responding to first-line therapy in spite of being a pan-susceptible isolate? And in NIRT Chennai, they identified that the TDMs were low. Therapeutic drug monitoring of the drug levels for the antibiotics, the antitubercular drugs were low, and she was ultimately treated with pyrazinamide, amikacin, linezolid, and delamanid. In spite of not being an MDR, she had to give these injectables as well as oral drugs with higher bioavailabilities to treat her. Second case, this is a lady, 70-year-old lady. She came with axillary adenopathy, an abscess, and mediastinal adenopathy on February 2020. You see, there is pleural thickening here at the time of presentation, and there is a small pleural effusion here. We thought that while giving ATT for the lymphadenopathy, this will resolve. But in August 2020, she became worse. She came with a massive pleural effusion. She was admitted, and the effusion was drained. It was found to be an empyema. But the unfortunate thing in this case was the cultures were always negative. She was caseating granulomatous lesion in case of lymphadenopathy histopathology. The smear was negative. Cultures were positive. Cultures were negative. GeneXpert was positive. Rifampicin resistance was negative. Follow-up also, it's the same thing. Cultures were negative. GeneXpert was positive. Smear was negative. So we decided to send the pus. That is the only thing that is available for whole genome sequencing. So we sent the pus. We found that INH resistance to INH, Uflox, Moxiflox was resistant. It was not an MDR. Rifampicin was not resistant. Lineage 1. Now, this was the peak of COVID. And this lady said, being a 70-year-old lady, she refused to take injectables, aminoglycosides. She was not able to take it because of the COVID, waiting injectables, many other reasons why she refused to change the antibiotic treatment. So we restarted the ATT. On the first line again, we restarted the ATT. And fortunately, she recovered. This is the X-ray. In February 2021, the pleural effusion has recovered, and she's recovered completely with the first line. We didn't intervene or didn't change anything because of the obvious reasons that she was not able to take additional drugs. But this pleural thickening is still there. That was there even at presentation in the first place. Now, this is an interesting case where we had a brain abscess. This is a child on congenital heart disease, long-term follow-up in our hospital. The child was for follow-up for correction of his heart anomaly, and suddenly the child lands up with a seizures, and we see a brain abscess. The pus was smear positive for AFT, but unfortunately, GeneXpert came negative. And if you have a smear positive and GeneXpert negative, the first thing that comes into your mind is non-tuberculous Mycobacterium. However, the culture grew Streptococcus species. We treated the Streptococcus species, and culture AFB was negative. Culture AFB was negative. Only smear AFB was positive, and it suggested non-tuberculous Mycobacteria. There's no reason why this child should have a non-tuberculous Mycobacteria. So we withhold the TB treatment. We didn't consider the TB treatment till we got a whole genome sequencing of the pus done. We did the whole genome sequencing. We found that it was MTB, not an NTM, susceptible, pan-susceptible, lineage 1. First line ATT was started only after whole genome sequencing report came. So this treatment was decided only after the whole genome sequencing came. So there was no reason why to withhold the ATT again. Continued the ATT, and the child recovered from the infection. This is a case of intestinal tuberculosis treated for 1 year. 1 year intestinal tuberculosis was being treated for 20-year-old female. She comes back with a large ileus abscess. This is the large ileus abscess on the right side. So initially it was intestinal biopsy showed granulomatous lesions, smear was negative, culture was positive, GeneXpert was positive, rifampicin resistance negative. First line ATT for 1 year it was given, and then she comes with the large ileus abscess. Pus was drained, again smear was negative, cultures was positive, rifampicin resistance was negative. In GeneXpert, whole genome of pus and MTB isolate both present. What did we find? We found some discrepancy. Both were successful. Culture isolate showed INH resistance. The SNP, the mutation was of minimal confidence level. So it may not produce a phenotypic resistance. Pus, all were sensitive. So there is a discrepancy between the pus and whole genome sequencing of pus and the culture, because the culture will need good amount of DNA, good amount of coverage of the whole genome of the bacteria, but the pus may not have achieved that much coverage of the genome because of the low amount of DNA. So there is a discrepancy. So you should understand that if you send a direct sample, it may be different. The whole genome sequencing result may be different because the amount of DNA is not that great. It was lineage 1, not an MDR, continued on first line ATT. Again, this lady must be having some issues with the absorption of the ATT. We sent her to higher center for doing a therapeutic drug monitoring to find out whether the drugs are achieving good concentration, because she's not responding to first line in spite of being pan susceptible. This is the last case of case 5, cervical lymphadenopathy. Now, this was a migrant laborer who was diagnosed with cervical lymphadenopathy, a TB on histopathology. GeneXpert was traced. It's not unusual to find trace in extrapulmonary samples, and rifampicin risk was indeterminate. So we thought that the patient may be having MDR TB, so why don't we send a whole genome sequencing for the tissue as well as the culture isolate? Unfortunately, both of them failed. So it's a mix and match. The whole genome sequencing of both isolate and tissue failed, and we couldn't get a report out of it. So to summarize the whole 5 cases, in the first case, the sample whole genome sequencing failed, culture was successful. Second and third case, cultures were negative. So we were saved by the whole genome sequencing from the direct sample. Case 4, both were successful, but there was some discrepancy because of the amount of DNA and the coverage that was good in case of isolate, and they found INH was there, but the resistance was minimal confidence, so does not confer phenotypic sensitivity resistance. And case 5, both sample and the tissue failed for some unknown reason. Both of them failed, so we couldn't get a report for that. Now, then next we sent 6 isolates which were rifampicin resistant by GeneXpert. So GeneXpert done on the direct sample was resistant. The culture isolate were available. We sent the whole genome sequencing of the culture isolates only, because that's the best sample to send for whole genome sequencing, because the amount of DNA would be very good and the coverage would be more than 99%. Coverage of the whole TB genome would be more than 99%. The depth also would be very good. So 3 samples, and we were surprised what whole genome sequencing told us. Pre-XDR, it's very unusual to get MDR in a center. We have only 1 or 2% of MDR isolates. So we got a pre-XDR. All the 3 were pre-XDR. All were different lineages: lineage 2, lineage 3, lineage 1. If you look at the general distribution of lineages, South India is more of lineage 1. North India is lineage 3. And lineage 2 is well distributed all over India, and it's more commonly seen in Northeast. So we found all the 3 lineages. And when we looked at the history, it suggested XDR, because there was a history of TB, previous history of TB in both the cases. Both 2 cases, previous history of TB was there. And this particular lady was from Delhi. So not a surprise that she had lineage 3. North India, you have lineage 3, South India lineage 1, and lineage 2 is all over India. And this particular also pre-XDR, but we had lost to follow. These cases went to the government for treatment, for further treatment. So we don't know what happened, but they were identified as pre-XDR. It was really surprising. We could have only known by whole genome sequencing that they are pre-XDR. Then 3 more isolates, which were rifampicin resistance by GeneXpert. And we had the isolates we sent for whole genome sequencing. It's interesting. You see the first isolate, when we did the DST, phenotypic DST with midget, it was sensitive. Expert says it was resistant. WGS whole genome sequencing identified a mutation, and it reported it resistant. Now, this particular mutation of 435 tyrosine is known to produce low-level resistance. Low-level resistance in the MICs would be on the lower level. The cutoff of 1 milligram used in case of phenotypic DST will not pick up this resistance. So WGS also reported resistance because it has got high confidence. Mutation was found. The expert also reported, but DST will come sensitive because the MICs are on the lower end. 1 milligram cutoff will not pick it up. So it is a resistant isolate, but phenotypic susceptibility will be seen because it will not be picked up by the breakpoint of 1 milligram. So that you should always remember. That's the beauty of knowing what mutation is there in the rifampicin and how to interpret, make sense of this discrepancy. The second, you see the rifampicin resistance, DST is again sensitive, that the whole genome sequencing didn't find any mutation and rifampicin was sensitive. Why was it resistant? Now, when we look at this was Ultra, and we looked at the Ultra graph. The Ultra does a melting curve analysis of mutant probes and the wild probes. When we looked at the Ultra graph, it suggested heteroresistance. Heteroresistance means you have 2 populations of sensitive and resistant in the sample. Heteroresistance was suggested by presence of both mutant probes as well as the wild probes. That's how we identified it's a heteroresistance. So sample showed heteroresistance, but the culture showed sensitivity, because when you culture the heteroresistant sample, due to the fitness cost associated with resistance, the bacteria which is susceptible will grow. The culture produces a susceptible growth, and when you do a DST of susceptible growth, you will find it to be sensitive. So whole genome sequencing also will come susceptible because you have grown a susceptible isolate. So that's the logic or reason that we gave for this particular isolate being expert resistant, heteroresistant phenotype, where both mutant probe and the wild probe were amplified. In the third case, you see rifampicin was resistant, DST was also resistant, and WGS also identified a mutation, lineage 3, rifampicin was. Now, if you look at literature, these 2 mutations are resistant to rifampicin, but they are sensitive to rifabutin. If rifabutin is available, you can actually treat these patients with rifabutin. Rifabutin, I assume, is available in government setup for latent tuberculosis. If rifabutin can be used in such cases, if you know there is mutation and also know that this confers resistance to rifampicin, but they are sensitive to rifabutin. So that sort of detail can be only got when you do a whole genome sequencing and identify the mutations responsible for the resistance. Then this is a study. This is not a evaluation. This is a very beautiful study where they found that they can use whole genome sequencing to identify outbreaks. Now they sent 6 isolates. This lab in Korea sent 6 isolates for whole genome sequencing. The first and the 6th patient were smear positive. They had active tuberculosis, and they don't have any doubt that they are tuberculosis patients. But what happened to 2nd, 3rd, 4th, and 5th patient? They also grew Mycobacterium tuberculosis. And they were very skeptical why they grew a Mycobacterium tuberculosis when they didn't suspect TB in the first place. On whole genome sequencing, they found all were lineage 1. All had the same pre-XDR pattern, except for the number 6, which had a different XDR, pre-XDR pattern. So all isolate number 1 to 5 had the same XDR pattern, pre-XDR pattern, and they were all lineage 1. And when they did a cluster analysis, they found that the isolate number 1 to 5 were clustered together because they had SNPs less than 10 SNPs. They are all identical. And isolate number 6, 1 and 2, that is 2 isolates of that patient, were clustered together. They were identical. So they came to the conclusion that clinically they did, patients 2 to 5 didn't have any tuberculosis, but gave the same cluster, belong to the same cluster, means the lab has contaminated the specimens. So these patients didn't have tuberculosis. They didn't treat the patients for TB. They discontinued the TB patient TB treatment if it was initiated based on the whole genome sequencing study by identifying that there was a cross-contamination in the lab. Only patient number 1 and patient 6 were actual pre-XDR cases, and they went ahead with the treatment of these 2 patients. But that is the beauty of whole genome sequencing, where you can identify clustering, outbreak, and differentiate it with contaminant if you don't have a clinical correlation with the patient. So this is a snapshot of TB in India. We all know about it. We have the highest number of TB patients. 27% of the TB burden, 27% of the rifampicin resistant TB also in India. Highest. And MDR TB is 3% in case of new cases, 12% in case of relapses. Rifampicin more resistance is negligible. So if you find a rifampicin resistant by GeneXpert, invariably it's in MDR. You can consider it as MDR because INH is also there, must be there, or some additional resistance is also there. That you will come to know only if you do a DST or you do a whole genome sequencing. INH monoresistance, however, is 4% in new cases and 8% in case of relapse. This will not, you will not do only with GeneXpert. You will have to do a phenotypic DST, or you have to do a whole genome sequencing. If you identify the lineage also, it makes some sense because MDR rates are higher in lineage 2 when compared to lineage 3 when compared to lineage 1. Lineage 1 is in South India, lineage 3 is in North India, lineage 2 is all over the India, but lesser number. So that is how the lineage distribution is there and how the prevalence of MDR and lineages. So what is the advantages of WGS? To summarize, it's helpful when the cultures are negative and you still have a doubt whether the patient is having MDR TB, provided the lab does it on direct samples. Confirm MTC complex. If you have, we have seen cases of Mycobacterium bovis BCG because of the BCG injections that is given to the bladder cancer patients. They develop the urinary symptoms and they grow Mycobacterium bovis BCG. So there you have a chance of identifying whether it's a BCG infection. What is the advantage of knowing Mycobacterium bovis BCG? Because they are inherently resistant to pyrazinamide. So you can avoid pyrazinamide treatment in such cases, bovis and BCG infections, if you are having it. Then you can identify true MDR cases, monoresistant cases, rifampicin resistant, rifabutin susceptible patterns. I have told you. By identifying the mutation, you can identify whether it's rifabutin susceptible and rifampicin sensitive. Pre-XDR, XDR cases, it was an eye opener for us. We found 3 pre-XDR cases because we don't have MDR cases that many. Mixed infection with MTCs. Mixed infection means 2 resistant phenotypes, or you have an NTM infection, co-infection. Lab cross-contamination can be identified, outbreaks, recent transmission can be identified, reinfection, relapse. So there are plenty of opportunities. That's why I call it, it's a Swiss Army knife. You can get a lot of data, a lot of interpretations from the data you get from whole genome sequencing. So where to use? Do not use it for detection. Now you can't use a sword where you can use a needle. So you can't use whole genome sequence for detection. I do some 350 GeneXpert per month, so I can't replace it with whole genome sequencing. GeneXpert gives you a report in 2 hours and whole genome sequencing in 14 days. There is no sense in using whole genome sequencing for detection. Best results, you send a culture isolate. The depth is good, the coverage is excellent, and the reports will be good. Direct samples have got a lot of limitations because there is interfering human DNA, other bacterial DNA, and inhibitors. So that outcome, the report may not be that great, and most often it will fail also. Results may vary with quantity of DNA in the sample. Regulatory approvals, validation, standardization is not available as of now. It's just on research use being done. Benign SNPs will not cause resistance. So overcalling of variants will cause over resistance. You have to have a very sound bioinformatic person, a molecular biologist, to identify the mutation and tell us with good confidence that this is associated with resistance. So there are different databases, and these databases needs to be standardized for clinical use. So they have to come up with a single database all over the world which tells you exactly whether it is associated resistance or not. So there should not be any ambiguity whether it can be reported resistance or cannot be reported resistance. And you have to understand that the control used in all whole genome sequencing is S37RV. S37RV is lineage 4. What we have in India is lineage 1, lineage 2, lineage 3. We don't have lineage 4. It's European strain, European lineage, so it's not there. But having said that, they say that it doesn't make any difference in interpretation of resistance. All of the lineages have the same sort of resistant mutations. So who can benefit from WGS? Where to apply it? Think of WGS when you have Mycobacterium tuberculosis isolates for patients who have high risk of MDR TB, close contacts, defaulters. Rifampicin resistance by any method, if you have an isolate, send it for whole genome sequencing. It could be a pre-XDR. Patients whom first and second line drug therapy has failed, to find out whether they are MDR, XDR, pre-XDR, or whether they are having a problem with the absorption of the drug. They may not be having good TD in the drug levels. That must be the reason they are failing, not exclusively because MDR or XDR. Patients with past history of tuberculosis is a must. Anybody with past history of tuberculosis, send him for whole genome sequencing. He may be a case of pre-XDR. You will identify only after he defaults and comes back again or relapse again. So it's better to send a whole genome sequence. So again, pillars of mycobacterial diagnosis. Smear AFB is only for detection. AFB culture, detection, identification, and DST, but takes a long time. DST takes another 3 to 4 weeks. CBNAT, an excellent method for detection, identification also, but it won't differentiate between the Mycobacterium tuberculosis complex members. And partial DST, partial, either rifampicin, or if you do an XDR, MDR, GeneXpert XDR cartridge, you can get 6 more drugs. LPA, at the most, you can get partial DST of 6 drugs. Identification. LPA can only be done in patients which are smear positive. Whole genome sequencing, only identification, complete DST. Whole genome is complete DST for 18 drugs. Cluster analysis, know whether there's an outbreak or a contamination, also can be achieved. There are many things that you can achieve with whole genome sequencing, but better use it for only clinical isolates. Direct samples, if the lab does it, go ahead and send it. So the algorithm, after listening to whole genome sequencing, would be something like that. You have a clinical suspicion of TB, smear AFB, culture AFB, CBNAT is positive. You can put a whole genome sequencing here. You can include a whole genome sequencing if the culture is positive, CBNAT is positive for high or moderate level, and smear is positive 2+, 3+. You can set for whole genome sequencing. The lab, if the lab accepts the sample also for whole genome sequencing. Then the traditional LPA, DST, expert MDR TB, XDR can also be done if you have the access to all these things. But whole genome sequencing would be the best option to get a complete DST in 14 days. Now, there are 2 studies, 2 very landmark studies that whole genome sequencing was done in India. These were South Indian isolates. They found that there was, now using whole genome sequencing only, they could identify there was intense patient-to-patient transmission in the individual treatment centers. The treatment centers were hotspot for transmission. That's how they identified with, that's what they identified with whole genome sequencing. And they identified a lot of new mutations in Indian isolates, and for which no data is available whether the phenotypic susceptibility is there or resistance is there. And they found 27% of the rifampicin resistant strains lack mutation in the RPOB region. That is alarming because most of our MDR or rifampicin resistance is detected by GeneXpert or TrueNat using the RPOB region alone. So we'll be missing 27% of the resistance. This is another study, whole genome sequencing in North India. They found the lineage 3 was more common in North India. 20% of them had co-infection in the NTM species. That is alarming. They can only be found if you do a whole genome sequencing. And they have also identified a lot of SNPs, newer SNPs for which no data is available. whether they are phenotypic, susceptible, or resistant. So you need a lot of studies to be done to identify many novel mutations whether they confer resistance or not. So commercially available whole genome sequencing that I outsourced was from FocusTB, Thyrocare. It's supported by HaystackAnalytics. They do a whole genome sequencing. They don't do a targeted NGS samples. They receive all TB samples provided they are culture positive. They do a culture. They do a smear. And culture is positive, the isolates are sent for whole genome sequencing. So you have to wait for the culture to come positive. You have a good culture setup in your place, you have the isolates, send the isolates directly. It takes 14 days after culture positivity for them to come up with a whole genome sequencing report, which cost only 7,000 rupees. Now, the first line DST also costs something around 6,000 rupees. So you have an option of sending whole genome sequencing for 7,000 rupees with a TAT of 14 days, or a conventional DST for first line drug, 5 drugs for a TAT of at least 3 or 4 weeks. So you have an option of a very good option, very robust, cheap option of doing a whole genome sequencing. The culture isolate is there. So always send a culture isolate for whole genome sequencing to FocusTB. It will give you a report at 14 days. Now this is how the report looks like. It's a 3-page report. The first page contains the patient details as well as summary of the identification. You have identified Mycobacterium tuberculosis, the lineage, which is lineage 1, 2, 3. Lineage 2 is called as a Beijing strain, whether it's pre-XDR, XDR, MDR, or pan-susceptible, and the coverage. The coverage is excellent because 99% coverage of the whole mycobacterial genome is achieved because you send an isolate. And the coverage, depth of the coverage is 154. That is very good. When you have number 1, and anything above 10 is excellent. 154 is very good. If you send an isolate, it gives you a very good coverage, good depth, and the data is very robust. Second is you very simply, in a very simple manner, they tell you which one is sensitive, which one is similar to a DST profile of a E. coli or Klebsiella. They say it is resistant sensitive. And then the next page, you find the mutations that conferring resistance. They identify the mutation, the substitution, and ultimately the gene that is responsible. And they also send you the PubMed indexation number, also the reference that they used, and the confidence level, whether it's high confidence or moderate confidence or minimal confidence associated with this gene mutation SNP. So this is how a whole genome sequencing report is very exhaustive, very nicely. And you can read these mutations and find out what this actually means if you are interested, and come to a conclusion whether rifampicin is sensitive, rifampicin could be resistant, or it confers low-level resistance, high-level resistance, so on and so forth, if you are interested. My acknowledgements: FocusTB, Thyrocare Technologies, HaystackAnalytics, IIT Mumbai, who helped me with the whole genome sequencing of the isolates, my clinicians from pulmonary medicine, pediatrics, neurosurgery, and my lab staff. Thank you. If you have any doubts, you can ask.
Thank you, Dr. Anil. This was an excellent talk, and really, so it's held us all spellbound. I'm sure there will be a lot of compliments. What we will do is I will also ask Dr. Chaitali to start with her talk, and we can have the Q&As at the end of the session, if that is okay. Dr. Chaitali, please.
Thank you, Dr. Anilkumar, for such a lovely and informative, wonderful talk. It's quite exhaustive, but it's very straightforward. So I'm starting my talk. I will not take much than 10-15 minutes because of the short of the time. So these are my key objectives: are molecular tests currently employed in TB diagnostics and how WGS can add value in increasing access to UTST. So I'm not investing much of the time, as Dr. Anilkumar has already spoken about this, but even though it's 10 million new cases in this Venn diagram, you can see per year, estimated 500,000 new cases with MDR TB, 1.2 million deaths from TB, 3.4% of a new and 18% of a retreatment cases shows some type of a DRTB. Only 37% of these are diagnosed and 30% of these receives an appropriate treatment. So when it comes to UDST, it is for rifampicin, we are seeing only 465K numbers when it comes to rifampicin testing by UDST. But whatever is the isoniazid resistant, which is a monoresistant, or maybe any kind of DRTB, which we missed, is 1060K numbers, which are rifampicin susceptible, but other type of resistant, that is the isoniazid resistant. This is showing in a global tuberculosis report 2020. So solid culture DST, liquid culture DST, and molecular methods really shines to rapid and accurate diagnosis with accessible DST. But then there is now time to usher into the new era for a TB diagnosis. So as we all know, there is a culture, and few of are the marked disadvantages that no one can wait for 3 to 6 weeks if it is a liquid culture and 8 weeks if it is LJ. Then it is a slow, having biosafety hazard, requires trained technicians. It is less potential of a cost reduction and requires negative pressure rooms and segregated workflows. This is the genotypic DRTB DST current molecular methods, which has been already discussed, but I'm just telling the detection, which is probe based and cost is around 1,500 for one drug, whereas for line probe assay, this is for first line and second line inclusive both of 3,000 rupees. This is a paradigm shift when WHO has endorsed GeneXpert in 2010, and that has reduced the time from 2 months to 2 hours. GeneXpert is a single drug target molecular expert method, which is an integration of different technologies, inclusive of molecular beacon, real-time PCR, resistant associated mutations, fluorometric probe, fluidics, and sonic bacterial disease. It is a random access on demand quality control system with minimum hands-on time and the training, which is most needed in appropriate setup of TB detection. Then there is the Expert Ultra has been developed, and it has been developed to detect more sensitivity, that is HIV TB also. It is improved the detection limit and sensitivity and specificity of rifampicin resistant to know the silent mutation. But here is a gray zone that it should be used only for sputum, and if it is a EPTB, then here is a sensitivity and specificity based on the sample type. And if you can see it carefully, for pleural flight, such an important sample, it is having a sensitivity of 17%. This is another instrument which is deployed into the setup for TB diagnosis government now, that is a TruePrep and TrueNat. Here are the few of the publications. Then next is a line probe assays, which is based on the key steps of a DNA extraction, amplification, hybridization, and analysis. These are the few attributed and advantages of this. This is a highly sensitive and specific. It detects both rifampicin and isoniazid in first go. It means for a low and high throughput labs and shorter turnaround time, 5 to 6 hours, if you are doing time to do it in a same day. And it is affordable, as we all know. It is for first and second line. It takes around 3,000 rupees. Disadvantage as compared to GeneXpert, it cannot be used for point of care testing. It requires biosafety cabinet and requires trained personnel. Again, if you have to interpret, you require a technician who is well trained in this, where we have to check for all the bands which are present. Then again, you have to match the intensity of the band when it comes to the mutation or wild type or mutant band. Then we have to make sure for which interpretation or which test version we are doing it. So taking the molecular to one step further, it is XDR, Expert XDR, which detects the mutation or for isoniazid, fluoroquinolones, camnamycin, and amikacin based on the molecular beacon and TM, that is a melting curve technology. Why do we need sequencing today? Here's the answer. The impact of a new definitions of DRTB, which has been changed recently, issued with phenotypic DST and relapsed and treatment failure cases, as discussed earlier. Grouping of DRTB recommendation has been come from WHO, is divided into group A, B, and C as follows. And here is the glitch. If you can see for the second line drugs, genome sequencing defining mutations for a new definition of XDR-TB requires more than 25,000 of a nuclear base pair to be scanned. And now the methods which are deployed into the diagnostic methods, we are just scanning 34. Whereas for first line, number of nucleotides per BP to be scanned is more than 1,000. And for existing scenario, we are scanning just 7. So there is a minimal to moderate acceptable DST support to XDR or MDR TB. WHO is quite sensational in adapting and giving the spectrum of a current and future TB diagnostic, and they have already endorsed few of the tests for first line and second line, group A and group B and group C antibiotic. Another reason, if you can see, there is a huge imbalance in sequencing, whether yet to reach to the scale, as 57% of a whole genome publication is from the region that account only for 3% of a global burden. And the LMICs, including India, is not contributing more. This is the WHO catalog, which gives the confidence on reporting of a whole genome sequencing. I'm not going into the deep, but just to analyze and just to shortlist it, it has divided into the five group. Group 1 is shows the association with the resistance. Group 2 shows the association with resistant interim. Group 3 is uncertain significance. Group 4 is not associated with the resistant interim, and Group 5 not associated with the resistant at all. So based on this WHO catalog for mutation, it's very easy and giving confidence for the whole genome sequencing and even for the targeted genome sequencing to report the resistant with the high level or medium confidence. Here is the prediction of a susceptibility for the first and second line drugs. It is for first line, it is more than 91%, but for second line, it is quite challenging because of a wide CI and there is a less data available for the same. The whole genome sequencing and targeted genome sequencing differences has been already taken care by Dr. Anilkumar. I'm not going into the deep for the same. These are the few of the achievements of whole genome sequencing, that is a prediction of drug susceptibility and the resistance. Epidemiological analysis is a bit easier and then for research purposes. These are the existing guidelines, which is from 2018 to 2021, which shows that the use of whole genome sequencing for TB diagnostics. Why it is difficult to establish such a setup into the sequencing into the TB endemic country is because of economic. It is having a high cost of the platform, that is a CAPEX and OPEX is too costly. It requires technical expertise and personal, and also the gaps in knowledge of a new mutation conflicting drug resistance, and currently it is not a point of care testing. We at Thyrocare is ISO, NABL, and CAP and TB accredited laboratory for all the certifications. And recently, and last 1.5 years, we are in collaboration with HaystackAnalytics launched this whole genome sequencing test. It gives the antibiotic coverage of 18 antibiotics. Turnaround time is of 12 days. If your culture is doing, then it is maybe as less as 7 days as well. It gives us the strain identification, co-infection, and mixed infection information also. So this is the report format which has been already talked. So at Thyrocare, we are looking for a safer and automation with the lab flows and real-time digital data. Sorry, because of the time convenience, I've gone through a bit fast, but thank you. Open for any questions.
Thank you, Dr. Chaitali. As usual, though you said you've gone fast, but it has covered practically everything that you intended to cover. So thank you again. With that, I think we will come to the Q&As. I think the first question is by Dr. Suresh Kumar Mishra. I think Dr. Anilkumar, this will be directed for you. How much is whole genome sequencing helpful for treating an MDR TB patient with diabetic cardionephropathy?
Madam, okay, sir, thanks for the question. MDR TB can be diagnosed only if you have an isolate or a specimen which is smear positive or a GeneXpert positive, which is either moderate or high levels of Mycobacterial genome present in it. So only those samples can be sent for whole genome sequencing if the lab does a whole genome sequencing with direct samples. If the lab doesn't do a whole genome sequencing with direct samples, you have to send an isolate, Mycobacterium tuberculosis isolate, after growing it. Because isolate would be better because the depth of the coverage would be very good and the coverage of genome also would be very excellent. And you'll get a report in 14 days showing all phenotype, all resistant genotype for 18 antibiotics. So you need to send an isolate. If you have, irrespective of the condition, you have any condition, underlying condition, you have to get an isolate first. If the isolate is not there, you have to get a specimen, which is smear positive, at least 2+, 3+, which is GeneXpert positive, moderate or high, which is only these isolates can be sent for whole genome sequencing if the lab does it for direct samples. And it's a very good alternative to know MDR TB within 14 days. Hope that answers the question.
I'm sure that Dr. Mishra can type in his response. But meanwhile, what I'll do is also take a next question, which is this is in the chat section by Dr. Kiran Narayan, I think. Of course, you've been complimented, Dr. Anilkumar, for an excellent talk. The question is, in patients with post-pulmonary TB fibrocavity as sequelae with hemoptysis, we do a bronchial aspirate and we get specimen AFB positive, CV-NAT negative, culture negative, and WGS shows NTM. Could we take it up as a colonization versus infection? It's a very interesting question.
That's a very interesting question. A clinician only would know whether it's a colonization or actual pathogen. So NTM rapid growers are colonizers, but having said that, post-cavitary TB, etc., the colonizers are very difficult to eradicate. They keep growing every time you do a sputum culture. So you have to treat it, but any amount of treatment will not get rid of the colonization from the cavity. That is for sure. So it is a pathogen there which is colonizing the cavity. Whether the patient is having a hemoptysis, if the patient is having hemoptysis, then you have to look for other modalities of treatment because you are not going to eradicate the NTM from the cavity. So it is there. It can be a pathogen. If it's hemoptysis, you will have to treat it. You can treat it based on the species identification that your WGS has given. So based on the species, you can taper the treatment. But having said that, you won't be able to eradicate it from the cavity. It's very difficult to eradicate NTM from the cavitary lesions of the lung.
Another question, I think this also would be directed towards you. Also, Dr. Chaitali could take it up in another layer. Role of WGS on drug sensitivity of NTM and species identification of NTM. So I think both of you can add layers to this, Dr. Anilkumar as well as Dr. Chaitali.
If you ask me, I don't have any personal experience because I've never sent an NTM for WGS. But WGS can identify NTM, and Dr. Chaitali must be in a better position to tell me whether drug resistance also comes part of the whole genome sequencing of NTM or not. Dr. Chaitali?
Yeah, so definitely it comes, but if someone knows that, or the clinician definitely correlate it better as compared to, clinical utility and the outcome of the treatment which has been given. So definitely that is a part of our reporting format, but it has to be correlate clinically and suspicious also.
The most important part would be the clarithromycin susceptibility, whether it's sensitive or resistant in case of rapid growers, whether clarithromycin can be used or not, because it's a very good and very cheap, not cheap, good and oral option for NTMs, especially rapid growers.
I will just add my 2 bit at this point is that, WGS will definitely be able to tell you whether it is an NTM and or also tuberculosis. Having said that, again, if there are 2 or more, if there is a mixed infection with 2 or more lineages of Mycobacterium tuberculosis, it will be able to identify, like you've already said, but it will give a combined what is the resistance profile. It won't be able to differentiate what is going to be, of course, which is there between the which is the resistance profile of both the lineages. It will give you a combined profile, and I think that makes sense in the real world scenario also, because you're going to treat the patient as an individual. So what you see the heteroresistance, what you see the resistance profile will be a combined resistance profile of both of those. With NTM, I doubt if it does not give the drug sensitivity details, but will be able to tell you what is the species of the what is the NTM, because I believe there are more than, if I'm not correct, Dr. Anil, you can tell me, there are more than 125 different species of non-Mycobacterium tuberculosis, or what was I think previously known as MOTT.
Yeah, there are plenty of different species, but I was wondering whether you can look at the resistance genome that is associated with the clarithromycin resistance. So if you can look at those part of the genome, whether there is mutation or not, I think you could actually comment on the susceptibility of clarithromycin at least.
That is a very interesting thing, because you have like you said, bioinformatics is a very critical aspect when you're doing a whole genome analysis. So you have a pipeline which will bioinformatics pipeline which kind of determines that whether it is Mycobacterium other than tuberculosis. So what happens, the next step, what you suggest is very interesting, that the pipeline should also be able to identify the drug resistance or the drug sensitivity of NTMs, which could be a good initiative for us also at Haystack, and to take it ahead.
it's very, very interesting that people are talking about NTM when we are discussing TB, because people have gone beyond tuberculosis. It's very good. All AFB is not tuberculosis. There are NTM, so it's not tuberculosis by default. So this is the first baby step we are taking with WGS in tuberculosis. The next step would invariably look at NTM and get a full susceptibility profile for NTM, so that the treatment is also tapered or designed according to the whole genome sequencing. I think that should be the next step in whole genome sequencing in tuberculosis in India.
Definitely. One more last question, I think, considering that we are, we have our schedule from 7 to 8, but I'll just take this one last question. The rest of the questions we will try and answer by mail. So WGS importance in HIV, TB, MDR, XDR co-infection. I think this is Dr. Anilkumar.
The WGS, see, WGS significance is good for everybody who is having TB, irrespective whether it's HIV, whether it's MDR, XDR, anybody with TB, and you find that he has got a risk factor for MDR, pre-XDR or XDR, that he's a defaulter, he's a relapse, he's a reinfection, you send it for WGS, because we were surprised when we sent the rifampicin resistant isolates to whole genome sequencing. Almost 50% of us isolated, 3 out of 6 came to be pre-XDR. So whole genome sequencing only made us realize that we have a problem with pre-XDR in our MDR patients. So irrespective of the underlying condition, any TB patient, if you think there is a risk factor, if you have an isolate, send it for whole genome sequencing. You will be glad that you have done. Your patient will also be glad that you have done it.
Thank you so much, Dr. Anilkumar. Once again, I'd like to thank both our speakers, Dr. Anilkumar as well as Dr. Chaitali. It was a wonderful session. Everything was simply brilliant about the entire session. And we look forward to having many more such interactive sessions. So once again, thank you. And to all the attendees, we really appreciate, like Dr. Anilkumar has said, we appreciate you taking time off and attending it on a long weekend, on a Saturday evening. So any questions that have not been answered, please, we will try and respond over mail. Also, you can feel free to reach out to us at the FocusTB website. The details are already there in the chat box. So thank you, everybody, and have a nice weekend.
Thank you. Thanks, everyone.
Thank you, Dr. Thank you, Dr. Chaitali. Thanks, Ranjan and team.
Thank you, everyone.